Hello and welcome back for the second part of your chronic kidney disease, end-stage kidney disease presentation and information. So at this point, if you have not watched part one, I would suggest you go do that, or this is not going to make sense. So we are picking up with renal replacement therapy or kidney replacement therapy. If your body is unable to your kidneys are unable to perform the task that they are supposed to perform, then you may need replacement therapy for them. So this is going to come in the form of dialysis. So the types of dialysis we're going to look at are going to be hemodialysis, CRRT, which is continuous renal replacement therapy, and peritoneal dialysis. So we are going to look at each of those. I'm going to go ahead and show you this dialysis video, and then we're going to pick up with hemodialysis.
Your doctor may recommend dialysis, a procedure that removes waste products from your blood if your kidneys are not functioning properly. Healthy kidneys filter out waste, excess fluid, and electrolytes like potassium and sodium from the blood. These waste products exit the body through the urethra in the form of urine. If you have kidney disease, your kidneys gradually lose function, leading to an accumulation of harmful wastes and excess fluid in your body, increased blood pressure, and bone or blood problems. Dialysis can also be done to treat acute kidney failure, which occurs when your kidneys stop working suddenly, or to remove drugs or poisons from your body. In one type of dialysis, called hemodialysis, your doctor will use a machine called a dialyzer to clean your blood outside your body. Some weeks or months before you begin hemodialysis, your doctor will prepare a vascular access site on your body. Your doctor will create either an arteriovenous graft or an arteriovenous fistula to access your bloodstream. To begin, he or she will numb the area with local anesthesia. To construct an arteriovenous graft, your surgeon will make a small incision in your forearm and insert a soft plastic tube called a graft to connect an artery to a vein. To create an arteriovenous fistula, your surgeon will make a small incision in your skin and connect an artery with a vein to make a larger vessel called a fistula. Once your vascular access site has healed, your doctor can start hemodialysis. To begin, your dialysis nurse will insert 2 needles into your AV fistula or graft. Once the circuit is set up, your blood will flow slowly out of your body and through the dialyzer. Inside the dialyzer, your blood will encounter filtering fibers and an absorbent cleaning solution called dialysate. The fibers will remove waste and excess fluids and electrolytes from your blood. Your cleaned blood will emerge from the dialyzer and continue through the tubing back into your body through the second needle at your access site. When your hemodialysis session is complete, the needles and tubing are removed, and you can go home. In another type of dialysis, your doctor will use the membranes lining your abdomen, called the peritoneum, to clean your blood without removing it from your body. Before you begin peritoneal dialysis, you will have an operation to implant a soft tube called a catheter. Your surgeon will insert the catheter near your belly button, creating a port through which the dialysate will enter and leave your abdomen. Each peritoneal dialysis session is called an exchange, First, you will use your catheter to fill your abdomen with dialysate for a period of time determined by your doctor. Through the peritoneal membrane, waste products and extra fluid are continuously drawn out of your blood into the dialysate. Along with the waste materials it absorbed, the dialysate will drain out of your abdomen into a disposable collection bag during your exchange.
Sometimes you need to get away from the kids for grown-up time.
All right, sorry about that. I was not very fast on my ending of the video. So let's start talking about each type of replacement therapy. So first up, we're going to talk about hemodialysis. So hemodialysis can be used for patients who are acutely ill and require short-term dialysis, like an acute kidney injury, or with chronic patients. It prevents death from excess waste in the body and the electrolytes getting too out of control, but it does not cure kidney disease. So dialysis is not a cure. It is just a treatment to remove waste from the body and excess fluid, as well as excess electrolytes. It doesn't compensate for the loss of the endocrine or metabolic activities of the kidney. So it's not going to make up for the fact that we're not getting you know, the erythropoietin released, we're not getting the prostaglandin released, we're not getting that, it's not going to take care of the problems with the RAS system and instigating that high blood pressure. So it's not going to compensate for the other things. It is just going to remove waste and excess fluid and electrolytes. So most patients will receive intermittent hemodialysis that involves treatments 3 days a week, so 3 times a week, with an average treatment time of 3 to 5 hours. This is typically done in an outpatient setting. It can be also performed at home with the patient and the caregiver. So, but with home dialysis, it's typically the treatment time and frequency may be adjusted. So, hold on, I've got a dialyzer. So with hemodialysis, you have your artificial kidney is basically this dialyzer. So the dialyzer is a synthetic semi-permeable membrane that the blood is filtered through to remove the toxins and the desired amount of fluid. So in hemodialysis, blood is diverted to the machine and then through the dialyzer, oops, sorry about that, through the dialyzer, and to get the excess toxins out. The excess toxins are filtered from the blood and then the blood is then returned to the patient. It happens by diffusion, so toxins and waste products are going to move from an area of higher concentration in the blood to the area of lower concentration in the dialysate. So we've got blood coming in and then dialysate fluid coming in and out. The blood, as it goes in, it is highly concentrated, but then all of the toxins and things will move into that lower concentrated dialysate fluid and then be removed out. The excess fluid is removed by osmosis, so the water is the same. It's going to move from that area of lower concentration to the area of higher concentration for the osmosis movement. So the fluid is going to move from higher pressure to the area of lower pressure. So that is how we get rid of the extra fluid. So during that ultrafiltration of removing fluid, the fluid moves under high pressure, the area of high pressure to low pressure. So that is what we do to get rid of the fluid. So again, I've got a couple of these. I've got a couple of these dialyzers. So they've got tiny little, let's see if I can get my, there we go. We can see the little tiny fibers in there. It's full of these little fibers. And so the diacylate will go in there, will flow in as well. So it's got the ports for the diacylate to come in and out. Blood goes in and out. And in this process of going through here, it'll remove that excess waste and fluid out. So let's talk about access devices. So one access device that we'll have is going to be an AV fistula. So this is typically the preferred access for long-term dialysis patients. It is created surgically. It's usually in the forearm, but you may also see it in the upper arm or other areas, but it's typically, they'll start in the forearm. So what they will do is anastomosing or joining of an artery and a vein. After it will take 1 to 4 months for that to mature. It can't be used immediately. So this is back in that stage 4 of kidney disease. They may go ahead and place this fistula in preparation of needing dialysis whenever they do get to stage 5. When they do dialysis through the fistula, they'll put in 2 needles, one for blood to leave through, and then one for blood to come out to return to the body. They will be inserted into that vessel to obtain the blood flow adequate blood flow enough to pass through the dialyzer. So it has to have matured for several months before it's going to be able to be used. You may have patients to encourage those vessels to increase in size. You may see that they'll be doing like squeezing a ball, performing hand exercises to increase the size of those vessels. So this does last the longest. So it's going to be the best option for someone who is long-term going to be on dialysis. So nursing care, no blood pressures and no venipuncture on that arm. Also no tight clothing, no heavy backpacks up here at the shoulder. Basically nothing that is going to inhibit blood flow. So these vessels, it's going to create a lot of pressure in there. And turbulent blood flow. So if you put on a heavy backpack that occludes blood flow or put a tourniquet or a blood pressure cuff on, that increased pressure could cause a rupture at that. And that would be very bad to rupture that arterial connection. So no blood pressures, venipuncture, tight clothing, anything that's going to restrict blood flow. Things that we will assess for is to feel a thrill. So if you lay your hands on top of a AV fistula, if you haven't done so, what it feels like is almost like a cat purring. It's that turbulent blood flow is what you're feeling, and we call it a thrill. So we would document thrill present. And it really does just feel like a cat is purring underneath your fingers. The other thing we'll do is listen for the bruit, which is the sound of the turbulent blood flow. So hold on just a second. I'm just going to play this sound. Hold on. You hear the whooshing? It's that sound of that turbulent blood flow, that arterial blood mixing with the venous blood. So that is what you will be listening for. So assessment wise, you're also going to want to assess a distal pulse. So for instance, here you'll want to check a pulse down radially. We're going to assess for a good cap refill and color. Some complications of an AV fistula are going to include stenosis. So those vessels can harden. Also thrombus formation. Failure to mature would mean that these vessels never connected, never got large enough to be able to use. Infection is going to be a major risk, especially with accessing them regularly for dialysis. A pseudoaneurysm is also a risk. So it's if you have a collection of blood between the layers in the artery, and it may be pulsatile and would form underneath that vasculature. So that's something to look out for as well. Next up is an AV graft. So the difference is that it is artificial. So it's going to be an artificial, basically like an artificial fistula. So it is created by putting in a synthetic or a biologic graft material between the artery and the vein. It is used when the patient's vessels aren't suitable for an AV fistula. They have some sort of a compromised vascular system, like in diabetes. So if that is the case and those vessels are weakened for whatever reason, then they can use a graft instead. Complications are pretty similar: stenosis, infection. A thrombus in that graft is the biggest, most common risk with the AV graft, but same thing during dialysis. You'll see that venous needle and the arterial needle both put in to administer the dialysis, to pull blood off and then put it back in. So next up, we also have multi-lumen catheters. So these are can be put in radiology. They can be put in at the bedside if necessary. They can provide immediate access in an emergency. They are to be used for dialysis only. So they are to be used for dialysis only, and typically this is what it looks like. It'll have a red port and a blue port, so an arterial and a venous port. The terminology you may hear is vas cath or perm cath. So a vas cath is used in a more temporary, used more temporarily. So if your patient has these, a lot of times the dialysis nurse will then wrap tape around the top of these, because they are not to be used as IV catheters. They are only to be used for dialysis. Now, sometimes these will have a third port. I just didn't have one that had one, but there'll be a third port that is an IV port, and you need a special order to be able to use that as an IV access. Vas cath, as I said, is temporary. It may be tunneled or non-tunneled. So tunneled would mean they basically kind of create scar tissue right here when they tunnel it. And what that does is just decrease the chance of infection, creating that scar tissue there. And then a perm cath has a cuff in it. So it could be used for up to a year. So some of your patients that had acute kidney injury that it looks like they're going to need dialysis for a little while, they may use this. So it will have a cuff in it so that it doesn't, so it can't move. It'll have a cuff underneath the skin so it can't slide. So then it can be used for longer periods of time. Big risk with these, big things can be that they're temporary and the increased risk for infection. All right, so with hemodialysis, let's talk about some of the complications. So for patients receiving dialysis, it causes a disturbance in lipid metabolism. So it leads to hypertriglyceridemia, so high cholesterol, high triglyceride levels, which can lead to heart failure, coronary artery disease, stroke, peripheral vascular disease. So what you will see is that cardiovascular disease remains a leading cause of death in patients that are receiving dialysis. So that's going to be one of our complications. Another thing is anemia. So we may have some blood loss during hemodialysis or hemolysis of the red blood cells. You will also see gastric ulcers be present. So a lot of times patients are going to also just have a poor appetite. They've got that metallic taste in their mouth. They've got gastric ulcers. So you're going to have problems with GI issues. Other things we're going to see with our dialysis patients are going to be episodes of shortness of breath between dialysis treatments because of the fluid volume excess. One of the most common things you will see happen during dialysis is going to be the hypotension. So that will happen as the fluid is removed. So this can lead to what your patient may start feeling when they have that big drop in blood pressure is nausea, vomiting. They may feel diaphoretic, tachycardia, dizziness. So signs of poor perfusion when they have these drops in blood pressure, and they can be pretty dramatic drops in blood pressure. I've read some of you guys' dialysis out rotation journal or discussion board entries and about seeing that severe hypotension that happens with the hemodialysis. Muscle cramping may occur, usually later in dialysis as the fluid and electrolytes leave that extracellular space. Exsanguination could happen if the blood lines were to separate or the dialysis needles became dislodged. That can lead to exsanguination. Dysrhythmias may result from electrolyte and pH balances that happen during dialysis or with the removal of antiarrhythmic medications during dialysis. If those things are being dialyzed out, we'll talk more about medications that may get dialyzed out. We'll talk more about here in a few more slides. Air embolism is rare but can occur if air enters that vascular system. Dialysis disequilibrium results from cerebral fluid shifts. So as all this fluid is moving around, you may have a shift in that cerebral fluid also. So signs and symptoms of this include headache, nausea, vomiting, restlessness, decreased level of consciousness, and seizures. It's rare, and it's usually actually more likely to occur with acute kidney injury, just because in chronic kidney failure or disease, end-stage kidney disease, those patients' bodies have adjusted to those shifts more than if you had somebody in acute kidney injury that is all of a sudden having these fluid shift problems that they've not dealt with before. Angina or chest pain can occur. Remember, our patients are often anemic and have heart disease. So remember, with anemia, those oxygen carrying red blood cells may be in short supply. You can also get a pyrogenic reaction. So an acute fever may come on if it is if there is a contamination somewhere in the system. I think I hit on everything else. Sorry, that was not in order. Okay, so let's look at our next bit here. So continuous renal replacement therapies. So CRRT. So what is happening here? So with hemodialysis, you are going for intermittent dialysis. As I said, typically as an outpatient, 3 times a week for several hours at a time. With continuous renal replacement therapy, it is continuous. That's what it's doing. So you've got a machine that is continually removing blood for cleansing and and then returning it to the body. So this would be indicated for acute or chronic kidney disease patients who are too unstable for traditional dialysis. So remember, we just talked about all those fluid shifts and the hypotension and all these things that can happen. Well, if your patient's too unstable for that big fluid shift, then we'll do it continuously. So that would allow for the fluid and electrolytes to just be slowly and continuously dialyzed out, similar to what your body normally does on its own. So this is, again, it's used for people who are too unstable. We can use it for fluid volume overload with kidney disease. Also for people whose kidneys cannot handle their acutely high metabolic or nutritional needs. So think about, you just went through your burn patients. So they have these super high metabolic nutritional needs. If their kidneys can't handle, they're already sick, they're damaged, they've probably gone through shock, that those kidneys can't handle that high protein, high nutritional needs, then we'll put them also on CRRT to give those kidneys the help they need at that time. So with the CRRT, you may see just hemofiltration or ultrafiltration, just fluid removal. For patients who are just in fluid volume overload, they can do continuous ultrafiltration and removal of just fluid. And it's tolerated better with our unstable patients because it's slow and continuous. Or you may see it with hemodialysis also, where they're adding the dialysate, and removing the toxins and electrolytes along with the fluid. All right, so important stuff. What do we need to know as nurses? What are we going to do for these patients? So one thing we're going to do is weigh them before and after their dialysis. Remember that they're going to be going 3 times a week for around 4 hours. So we are going to need to do some emotional support for these patients, some encouragement. So other things, let's talk about the medications and what we need to hold prior to dialysis. So we do want to hold blood pressure medicines and vasoactive medications prior to dialysis. Remember that dialysis can cause hypotension. So if you have administered blood pressure medications or vasoactive medications ahead of time, that could lead to a dangerous level of hypotension. So make sure those are being held until afterwards. Also, water-soluble medications like vitamins need to be held until after. The same is going to be true of diuretics. So before dialysis, holding water-soluble meds like multivitamins or any kind of vitamins, all diuretics, blood pressure, and vasoactive meds need to be held ahead of time. So I am now going to share with you a video of a gentleman that is going through dialysis.
My name is Ben Gray, and I'm a diabetic. I have type 2 diabetes. I work for the city of Chicago, and I get up in the morning, get ready, and hit the street. I didn't know that diabetes and kidney failure were like hand in hand, so to speak. One would start, the other to happen. Otherwise, I would have jumped on it seriously in 1992 when I first was diagnosed with it. I'd have changed my diet right away. Probably would have ate any more cookies and ice cream, and I would have went to the club and would have dropped 20 pounds right away. A couple of years later, the things started getting worse. But I realized I got to take this thing seriously. I got to finally go on dialysis because I was at the lowest point that I could get to. My legs were swollen, my feet were swollen, couldn't get into my shoes, high blood pressure, impotence. You know, these are things they don't tell you about. When things start happening to your body that it's not working normally, you got to get that checked out right away. So I kept saying, all right, I'm going to try this a little longer to try to fight it off until I finally said, okay, set it up.
Different volt, 5.5. You're on it for 4 hours.
Dialysis is a form of, it's like an artificial kidney in a sense. It acts and does the things that my kidney no longer does. You don't urinate the same. Your body does not excrete the toxins that are in it. So once your kidney starts failing, you need this to live.
How you doing?
I come to dialysis afterward.
Yeah. You got a permit? Yeah, but I don't have it with me. I switched trucks.
Each session for myself is like 4 hours, 3 days a week. But if it means living, it's not a big deal, not a big choice to make. My doctors have, your kidney is failing, and you might consider going on dialysis because eventually you will start feeling bad. And if you don't do it in time, you could die. My significant other supported me 100%. To make sure that I was eating right, doing the right things, that I followed up on all the stuff that my physician said that I should do, and I should get in here as soon as I could to take care of this, and also pursue the transplant. They ask for a lot of tests before you can even be put on the list, so they're not just giving you a kidney because you need one. Most of the transplant centers also want you to be in pretty good general overall good condition and everything else. Mikey, I think my blood pressure is getting a little low. The 113. Yeah, I don't want to have a scene here, so maybe shoot me 100. I'm very active. I question things, I ask questions, I find out, I have them explain everything to me because I want to know what's going on. A dialysis patient has to help themselves too. When they give you your labs back, which they check once a month, and they show you what's high or what's low, what you need to do, you got to get this down, you got to take care of that. And you realize you still have a chance to straighten things out and still have a pretty good life. Then you start realizing how important life really is. You got to do something.
So we saw Ben and how the hours of the hemodialysis impact his life, but also he did have a really positive attitude about it, and really wanted to stay educated on top of it. One of the big things I think of with that video and listening to him share his story is at the beginning when he said, if I had only known, if I had known what was going to happen if I didn't control my diabetes, and that he didn't understand the damage that it was going to cause. So education is key in preventing kidney disease from taking place in these clients that are high risk. All right, so next up, peritoneal dialysis is this next piece we're going to discuss. So with peritoneal dialysis, it is the treatment of choice for clients with kidney disease who are either unable or unwilling to undergo hemodialysis or kidney transplantation. So typically these are clients who are susceptible to the rapid fluid shifts and don't tolerate hemodialysis very well. And peritoneal dialysis is a much slower fluid shift. So these are patients that may be more susceptible to that rapid fluid shift. Patients with severe hypertension, heart failure, pulmonary edema that are not responsive to treatment regimens, these may be the people that will be more susceptible and then use PD. So fewer than 8% of patients with end-stage kidney disease do actually use peritoneal dialysis as their treatment modality. So with peritoneal dialysis, the peritoneal membrane is semi-permeable. So a dialysate fluid is introduced into the peritoneal cavity through a catheter, and we'll talk more about this on the next slide also, at intervals, at established intervals. So it's a sterile solution. It sits inside the peritoneal cavity, and the toxins and things in your blood, such as the urea and the creatinine and other things, are then removed through diffusion and osmosis. So the waste products are going to go from, just like they do with hemodialysis, go from the area of higher concentration to an area of lower concentration, which is going to be that dialysate fluid. So through that semi-permeable membrane of the peritoneum. So inside, so let's see, let me get my little pencil. So we have the dialysate going in, it fills up, see this peritoneal cavity, this is that fluid filling up that peritoneal cavity. So it goes in and then it sits. You get that waste crossing across that semi-permeable membrane of the peritoneum and into that fluid, and then later then that fluid is drained out. So let's go to the next slide to talk more about that. So as I said, that peritoneum is a semi-permeable membrane. The access is a Tinkoff catheter. That's what we call the tube that is that abdominal access into that peritoneal cavity. With peritoneal dialysis, what is ordered for your patients is going to be an exchange. So an exchange consists of a fill time, so fluid coming in, a dwell time, so how long that fluid sits inside the peritoneal cavity, and then a drain. The draining of that liquid is going to be one exchange. So the sterile dialysate that it's filled, needs to be done aseptic technique. That liquid is sterile. The biggest risk and complication, which I'll get to in the next slide also, but the biggest risk is going to be an infection and peritonitis. So when maintaining sterility by using the aseptic technique is going to be priority when you are caring for a patient with peritoneal dialysis. Another thing is that that dialysate needs to be warmed. That is also super important. Cold fluid administration will cause severe cramping and discomfort for your patient. So that dialysate needs to be warmed. The effluent is what we call the drainage that comes out. That should be colorless or straw colored. It should be clear. It should not be cloudy. And straw color, really, it resembles urine because it is the removal of the waste. So water removal with peritoneal dialysis is done through an osmotic gradient. So we use a higher glucose concentration in the higher the concentration of the dialysate bag, the more fluid it will pull along with it, because again, higher concentration, the fluid is going to go there towards that higher concentration. So let me go ahead. So the higher the concentration, the more of the dialysate pulls off the fluid. So 4.25, 2.5, or 1.5 is how these bags are ordered. So the 4.25 is going to pull off the most fluid then. So I do have a setup here. So these bags are huge. So here we've got our big dialysate bag. This one is 1.5. So it's going to mostly remove waste and not a lot of fluid in your patient that is using it. So what the patient would do is hang this bag up on a pole. This end of this would attach to their Tinkoff catheter. It attaches to the Tinkoff catheter. And then there's also a drain bag. So there's this empty bag. So fill bag, connection, drain bag. So what would happen is they would leave that fluid in the peritoneum for the fill time, so, or for the dwell time. They would leave it there, and then when that time was up, then they would drain, and it would drain into this empty bag. So that's how that process goes. So different ways of delivering the peritoneal dialysis. The acute intermittent peritoneal dialysis is indicated when there are signs and symptoms of too much waste in the body. It's that acute, it's used to treat acute things. So if your client receives it, that is for the peritoneal dialysis in an acute situation. So their nausea, vomiting, fatigue, alter mental status because they've got too many waste products in their body. Acidosis, fluid volume overload, hyperkalemia as well. So it's not as effective as hemodialysis in removing all those things in the fluid, but it does allow for a more gradual change in the client's volume status and in the waste product removal. So that may be the choice for a patient that's not hemodynamically stable. So with the acute intermittent, those exchanges are usually every 30 minutes to 2 hours that they'll do that fill. Remember, an exchange is fill, dwell, drain. So an exchange every 30 minutes to 2 hours. Continuous ambulatory peritoneal dialysis is the second most common form of dialysis next to hemodialysis. So it is performed at home by the patient or by a caregiver, and it allows the patient to have a reasonable amount of freedom and control over their daily activities. It does require a commitment to be successful, but they generally exchange every 4 to 6 hours. So these patients are able, it is every 4 to 6 hours around the clock, but it does allow them to determine their schedule, and they can carry with them their stuff. So if they went on vacation, they could take their things. It means that they're not locked into having to be at a hemodialysis facility 3 times a week. They're able to go and do and just keep this schedule and take their supplies with them. Continuous cyclic peritoneal dialysis uses a machine called, so like what I was showing you is done by gravity. I had a patient who I took care of at home, who she was young, she was 30, and she had a congenital heart defect that was not good. And she had, I don't remember what her heart defect was, but she had gone through a heart transplant. And when she went through her heart transplant, she was very unstable for a while, and it led to an acute kidney injury from the lack of a pre-renal acute kidney injury, from lack of perfusion there to the kidneys, but she did not recover. Her kidneys didn't recover afterwards. And so she was on peritoneal dialysis, and that was what she did, was that continuous ambulatory PD. And so we use the gravity bags, and every couple hours we'd hang up meticulous hand hygiene and cleanliness of of connecting and disconnecting, but connect, fill, she would dwell, and then we'd drain. And so it did allow her, she did, she lived at home, she had a 4-year-old child, so she was able to still be present and be there for all those things with him. And then the continuous cyclic uses a machine called a cycler to provide those exchanges. So that machine will use overnight intermittent peritoneal dialysis with a longer dwell time during the day. So the catheter is connected to a cycler machine every evening, and usually just before the patient goes to bed at night. And so then the patient sleeps, and they use extra long tubing so the patient can move around, and it will cycle them at night. So they'll have a long dwell time during the day, and then they'll go through multiple exchanges at night while they are asleep. This does have a lower infection rate than the other types of peritoneal dialysis because there's not as many back exchanges and tubing disconnections. It also allows the patient to be free from exchanges during the day so that they can work and be at part of normal daily activity. So complications, the biggest complication, as I said, is going to be peritonitis. That's what you see the very most often, is peritonitis. So an infection, bacteria has gotten introduced into that peritoneal cavity. So fever, redness, extreme tenderness or pain in the abdomen are going to be signs of peritonitis. Also, if you see that when you drain, if it's cloudy, then that's a sign that there may be an infection there as well. Bleeding, leakage, and then also abdominal hernias because of increased abdominal pressure with all that fluid going in. All right, so as I said, you cannot, chronic kidney disease, kidney failure, it's not reversible. You can't go back and fix it after it's started. And the only way to regain independence from dialysis after end-stage kidney disease has taken place is for a kidney transplant. So it can be difficult to get a kidney transplant. There is a link here to the National Kidney Foundation that supports transplant. And we'll watch this video in just a minute about organ donation need. So just like Ben said in the video we watched with Ben on dialysis, they don't just give kidneys to just anybody. They want to make sure you're in pretty good shape. So some contraindications to being allowed to even be on the transplant list would be having a recent malignancy or cancer, an active or chronic infection, severe irreversible disease outside of your kidneys. So an inoperable cardiac disease or chronic lung disease, severe peripheral vascular disease, anything like that. An active ongoing infection like HIV, hepatitis B or C, class 2 obesity. So obesity with a body mass index greater than 35 is going to make it so that you would not be able to be on that list. Substance abuse, inability to give conformist consent, or a history of non-compliance to treatment regimens. As we'll talk about, just because you get that kidney doesn't mean that you cannot follow prescribed medication, because you're going to have to be on immunosuppressant therapy for the rest of your life. And so if you have a history of not following treatment regimens, then you will not, they may not give you a kidney. So donors may also be rejected. So donors may be deceased or they may be living, but living donors may be rejected for any reason that may indicate that their other if they give one kidney, that the remaining kidney may be in danger. So if the donor has hypertension or diabetes, both of those are known causes of kidney disease. So they may not take that other kidney, because every precaution is going to be taken to ensure that the remaining kidney in the donor will remain healthy. But if these conditions are met, the donor should remain healthy after the donation and have a normal lifespan. One of our kidneys can easily handle the body's needs as long as there's no illness there. Typically, whenever a kidney transplant is done, the recipient, they don't remove their kidneys, which I think is interesting, but their native kidneys are not usually removed. They will just attach a ureter, the ureter of the newly transplanted kidney, into the bladder, into their bladder, or attach that ureter to the ureter, to their ureter they already have. As far as if it worked or not, we'll talk more about this in a minute, but production of urine is going to be an important indicator of the procedure and how long the ultimate outcome. So prior to transplant, there's going to be a very detailed physical examination of both the recipient and the donor. Tissue typing, blood typing, and antibody screening are performed to determine if the compatibility of the tissues and the cells of the donor and the recipient to improve their chances of not rejecting that kidney. Both patients have to be free of any infection at the time of the transplant. And then, as I said, after surgery, medications are going to be ordered to prevent rejection. And so these medications are going to be taken forever and will suppress the immune response. So the recipient of an organ is going to be at risk for infection. Psychosocial evaluation is also usually conducted to assess the organ recipient's ability to adjust to the transplant. How do they cope? What's their social history? Do they have the appropriate financial resources and social support they need to be able to handle the organ transplant? Okay, so now we're going to watch this video about the organ transplant need.
Currently, there are 100,000 people waiting for an organ transplant in the U.S. alone. Nearly 7,000 people will die waiting for a transplant this year.
I feel if people knew more about dialysis, they'd be more willing to be an organ donor, and it would be a lot easier for people to live on dialysis.
Allison has been on dialysis for 9 years. 9 years, 15 hours a week of being hooked up to a machine that acts as her kidney.
When that happened to me, I had an adjustment. I really had to adjust my life.
Dialysis is the artificial process of getting rid of waste in the body. Normally, our kidneys would do this automatically.
I don't know how to explain it, but it's probably one of the worst things I've ever had to go through in my life.
Gabby is a high school senior currently on dialysis. She has recently turned 18, moving her to the adult transplant list, lowering her chances of receiving a kidney.
If you donate, or it could be like saving someone's life.
There's only so many organ donors out there right now, and there's tons of people waiting on lists, and some don't even make it to a transplant.
By becoming an organ donor, you can save multiple lives.
It really is a good thing. It's no risk to the donor, and it's a great thing for somebody else to give life.
Well, yes, I've had many obstacles, but it's still not, I still am not giving up.
There's people that wait like years for something and they die waiting.
Dialysis is a means to an end, but organ donor is the way to live.
Okay, so lots of people waiting for kidneys for lots of different reasons across the lifespan, many ages and things that are affected. So just because they get a kidney also doesn't mean that that kidney is going to work for them. They do all the testing that they can ahead of time to make sure that the body won't reject it, but that is not a guarantee. So different stages of rejection we are going to talk about. So these are pretty much separated when you're trying to remember them. Think of the time frame that we're looking at. So hyperacute, super acute. So hyperacute injuries within 24 hours, and these are typically caused by an immediate antibody reaction. So when that happens, it's going to lead to a generalized glomerular capillary thrombosis and necrosis. So when this hyperacute happens, it requires immediate removal of the transplanted organ. So how heartbreaking would that be, that it had to be taken out 24 hours or less after it got put in. So if you see a reaction within 24 hours, it's a no-go, and that organ's gonna have to come out. Super heartbreaking. Acute is gonna happen within 3 to 14 days. So if you see the reaction between 3 and 14 days, so not within 24 hours, but in less than 2 weeks, it can also go out to a little further, but typically within those first 2 weeks is what we're going to look at. The patient's going to experience tenderness at the transplant site, and you're going to see an elevation in those serum creatinine levels, fever, low urine output. If you catch this early, then what'll happen is they'll just increase they'll increase the immunosuppressant therapy, and hopefully they'll be able to hold on to that kidney. Chronic is going to be after many years. So even if you've had a transplanted kidney for a long time, you can still reject it anytime. As long as life goes on, it's still a foreign object, so it could still happen after many years. So what happens with rejection is that the immune system sees that transplanted kidney as a foreign object, and it tries to reject it, tries to get rid of it. So immunosuppressive therapy is absolutely necessary. It's going to be necessary to dose with immunosuppressive agents to prevent the patient's own immunologic response to that transplant. Otherwise, the body will reject that kidney. So when we are assessing for signs and symptoms of rejection, and this is with any of these stages, whether it's hyperacute, acute, or chronic. Signs and symptoms are going to be oliguria, so decreased urine output, edema, fever, an increase in blood pressure, weight gain, swelling or tenderness at that calf or at the graft site. A kidney from a related donor is usually, if it's somebody that's related to them, it usually begins functioning immediately after surgery. If it's related to a living donor, not that they're related, but if the kidney came from a living donor, it usually functions immediately after surgery. A kidney that came from a cadaver will usually undergo some acute tubular necrosis, and therefore it may not function for a couple weeks. So during that time, if it came from a cadaver, you may have a few weeks of anuria or oliguria, or even possibly polyuria when that isn't functioning correctly. So hemodialysis would still be necessary during that post-surgical phase. So other assessments that are needed. Biggest risk for patients who have received organ transplants is going to be risk of secondary infections. They are going to be on immunosuppressant therapy for the rest of their lives. So 75% of kidney transplant recipients are going to have at least one episode of an infection in the first year after transplantation. And it is a major cause of death for organ recipients. Then also you're going to just have your post-operative risks that are the same as all post-operative patients. So you're going to have risk of infection there at the surgical site. You're going to have risk of blood clots, pneumonia, all those things that you see with all surgical patients. So that is going to complete our renal content for Unit 5 for NUR213. I know that was a lot of information between the functions and all the things that go wrong whenever the kidneys aren't functioning, and the acute kidney injury and chronic kidney disease and diets and nursing interventions. It's a lot of information, and I get that. So if you have questions along the way while you were going through this content, please reach out to me. Send me an email, post to the discussion forum. Don't wait until the night before the test. Go ahead and reach out as you're studying and let me know any questions you have.